Welcome to This Week in Radiology. This week we're covering 9 notable papers spanning the evolving landscape of oncologic imaging, major updates in neuroimaging protocols and guidelines, and new thinking on diagnostic pathways for acute conditions. Let's dive in. The management of cancer continues to shift towards more personalized and less invasive approaches, and this week's literature highlights how imaging is central to this evolution. First, a multidisciplinary review in the European Journal of Radiology explores the role of MRI in the watch-and-wait strategy for rectal cancer. For patients who achieve a clinical complete response after neoadjuvant therapy, this organ-preserving approach is an alternative to total mesorectal excision. The review emphasizes that while evidence supports this strategy in select patients under strict surveillance, MRI is the cornerstone for both initial selection and the crucial task of detecting local regrowth early. However, the authors caution that challenges like inter-observer variability and non-uniform protocols remain significant hurdles for safe, widespread implementation. Similarly, a review in the Korean Journal of Radiology discusses moving beyond simple anatomy and pancreatic cancer staging. Treatment decisions have long been based on anatomical resectability, determined by tumor vessel contact on CT. This paper argues for an expanded concept that incorporates biological factors like CA-19-9 levels and PET activity to better stratify risk. A key clinical challenge highlighted is restaging after neoadjuvant therapy, where imaging often overestimates vascular invasion because it cannot reliably differentiate post-treatment fibrosis from a viable tumor, making these biological markers even more important. Shifting to genitourinary oncology, a paper in Radiographics provides a comprehensive update on the 2022 World Health Organization classification of renal cell tumors. This new classification introduces significant changes, including new categories for molecularly defined carcinomas. Notably, what was previously classified as papillary renal cell carcinoma type 2 has now been reclassified into other tumor types. For the practicing radiologist, this means that a tumor with features of a papillary RCC, but with atypical characteristics, like patient age, growth pattern, or enhancement, should raise suspicion for one of these rare subtypes. This is critical for guiding urologists and prompting pathologists to perform the necessary tests for an accurate diagnosis. Finally, in this theme, an article in the European Journal of Radiology investigates the impact of a commercial AI decision support system on biparametric MRI for detecting clinically significant prostate cancer. In a retrospective study of 52 men, AI assistance was associated with improved diagnostic performance. At the per-lesion level, AI improved sensitivity for 3 of the 4 readers and increased the area under the curve for all readers, without a significant change in specificity. The benefit appeared greatest for the least experienced reader, whose per-case sensitivity for the index lesion increased from 73% to 87%. The authors appropriately frame these findings as proof of concept, but they suggest AI has the potential to act as a valuable second reader, especially for those with less experience. In neuroradiology, the focus this week is on efficiency, safety, and staying ahead of new clinical guidelines. A paper in AJNR offers radiologists a guide to the upcoming 2026 AHA-ASA guidelines for managing acute ischemic stroke. While many core recommendations remain, the update will feature expanded guidance for medium vessel occlusions and, for the first time, introduce specific pediatric recommendations. This review serves as an essential primer for radiologists to anticipate and prepare for the coming changes to stroke imaging workflows. Directly addressing the pediatric population, another study in AJNR evaluates a rapid 2.5-minute brain MRI protocol for the emergency department. In a finding-enriched cohort of 100 studies, this multi-contrast neuromix sequence was found to be diagnostically interchangeable with the standard 15-minute protocol for detecting clinically relevant intracranial findings. The overall diagnostic accuracy was identical for both protocols at nearly 88%. This is a significant finding, as the dramatically shorter acquisition time led to fewer motion artifacts and could reduce the need for sedation or radiation from CT scans in the pediatric emergency setting. Rounding out our neuroradiology section, A third paper from AJNR questions the necessity of routine contrast administration in the follow-up of pituitary adenomas after surgery. This single-center retrospective study of 91 patients found that non-contrast MRI provided assessments of tumor volume, optic pathway compression, and cavernous sinus invasion that were broadly similar to those obtained with contrast-enhanced MRI. Inter-reader reliability for tumor volume was excellent for both methods. These findings suggest that for many patients undergoing routine surveillance beyond the immediate postoperative period, gadolinium-based contrast may offer little additional diagnostic value, paving the way for safer and more efficient follow-up protocols. Finally, 2 papers this week address refining our approach to common acute presentations. The Journal of the American College of Radiology published the latest ACR appropriateness criteria for epigastric pain. This document provides evidence-based guidelines for a diagnostically challenging symptom with a wide differential, including perforation, GERD, peptic ulcer disease, and hiatal hernias, both pre- and postoperatively. These criteria are designed to help clinicians select the most appropriate imaging study at the right time. And a review in the European Journal of Radiology explores an expanded role for cardiac CT in diagnosing Takotsubo syndrome. While cardiac MRI is considered the reference standard for assessing this acute myocardial dysfunction, it is not always available or feasible. The authors argue that modern cardiac CT has evolved beyond coronary assessment and can provide comprehensive functional and tissue characterization. They propose a diagnostic workflow that integrates cardiac CT into the multimodal imaging pathway for patients with suspected Takotsubo syndrome, potentially improving non-invasive diagnosis. If you only have time for one paper this week, make it the study on a 2.5-minute brain MRI protocol in the pediatric emergency department. Its demonstration of diagnostic interchangeability with a 15-minute standard protocol offers a tangible solution to the perennial challenges of motion, sedation, and workflow in pediatric emergency neuroimaging. Here are the key takeaways from this week in radiology. First, in oncologic imaging, assessment is moving beyond simple anatomy. For rectal and pancreatic cancer, imaging is being used to gauge biological behavior and response to therapy, guiding decisions like organ preservation. Meanwhile, new molecular classifications for renal tumors require radiologists to spot subtle imaging differences to guide pathologists. Second, in neuroradiology, efficiency and safety are paramount. A new 2.5-minute pediatric brain MRI protocol shows promise for emergency settings without sacrificing diagnostic accuracy, potentially reducing CT use and sedation. For pituitary adenoma surveillance, routine gadolinium may not be necessary for many postoperative follow-up scans. Third, stay ahead of guidelines. The upcoming 2026 stroke guidelines will bring changes to imaging workflows, particularly for medium vessel occlusions and pediatric patients. And for epigastric pain, the ACR has new evidence-based appropriateness criteria to guide your imaging choices. Finally, AI continues to show potential as a decision support tool. In prostate MRI, an AI system improved lesion-level sensitivity for detecting clinically significant cancer without a loss of specificity, with the greatest benefit seen among less experienced readers. That's your roundup for this week in radiology. The full transcript and references are available on the episode page in your AudioScholar library. This is an AI-curated summary. For clinical decisions, always consult primary sources and current guidelines. See you next week. This is an automated summary generated by artificial intelligence, which can make mistakes. Always review the original source materials.